Welcome to this Step 3 review, focused entirely on low back pain. This video is brought to you by Roadmap to Residency. Low back pain is one of the highest yield primary care topics on the exam, and the questions almost always test the same handful of decision points. Our goal today is not to reteach the entire subject. It is to show you exactly how the question stems are built, which details are red flags, and how to pick the next best step under pressure. We will cover red flags in imaging, conservative management, Cauda Equina Syndrome, and chronic pain management, and we will walk through practice questions together. Make sure you are also drilling questions in your question bank and reviewing the concepts in a trusted board review resource, because these patterns are best learned by doing. Let us get started. Here is what we are going to cover today, all through the lens of low back pain. First, we will learn to scan every stem for red flags and to know exactly when imaging is indicated and when it is a trap. Second, we will default to conservative management for the ordinary case, and we will learn to instantly recognize Cauda Equina Syndrome as a surgical emergency. Third, we will handle chronic low back pain with a stepwise, evidence-based approach. Along the way, we will work through several practice questions and explain precisely why each answer choice is right or wrong. This video assumes you already have baseline knowledge from your review resources. We are here to sharpen how you attack the questions. Our first and most important strategy is to scan every low back pain stem for red flags. Start with the last line of the question, because that sentence tells you what is actually being asked, whether it is the next best step, the most appropriate imaging, or the best treatment. Once you know the question, go back and read the stem hunting for danger signs. Every low back pain vignette is really a red flag test. Look for fever, unexplained weight loss, a history of cancer, recent significant trauma, saddle numbness, leg weakness, and any loss of bladder or bowel control. When those are all absent, the answer is almost always conservative care. When even one is present, the question is steering you toward an urgent workup. Train yourself to run this red flag scan every single time. Now let us cover our first topic in depth, which is red flags and when to image. First, memorize the red flag list, because it is the backbone of every low back pain question. The classic danger signs are a history of cancer, unexplained weight loss, fever with a possible source of infection, injection drug use, recent significant trauma, progressive neurologic deficits, and saddle numbness with bladder or bowel changes. Any one of these tells you that plain reassurance is the wrong answer. Second, image only when it changes care, and match the imaging to the suspected cause. Suspected cancer or infection points toward magnetic resonance imaging of the spine. A suspected fracture in an older patient or after trauma points toward plain radiographs. When there are no red flags, no imaging is indicated in the first several weeks, and that early scan is the single most common overkill trap on this topic. Our next topic is conservative management, which is the correct answer for the large majority of low back pain questions. First, stay active and reassure. For uncomplicated back pain, the winning choice keeps the patient moving, so advise activity is tolerated, reassure that most cases improve within a few weeks, and never prescribe strict bed rest because rest actually slows recovery. Second, choose first-line analgesia. The preferred medications are non-steroidal anti-inflammatory drugs, and you can add heat, gentle activity, and a short course of a muscle relaxant when spasm is prominent. Opioids are rarely correct for acute back pain, so treat them as a warning sign when they appear. Third, beware the overkill answer. The test writers plant an impressive option, like an immediate scan or a surgical referral, for a patient with no red flags. Doing too much is wrong just as often as doing too little, so choose proportionate, conservative care every time. Let us work through our first practice question, and it tests red flags and conservative management. A 38-year-old man comes to the clinic with low back pain for 1 week after lifting boxes during a move. The pain is worse with bending and better with rest. Read the next part carefully because the stem walks through the red flags and tells you they are absent. He has no fever, no weight loss, no leg weakness, no numbness, and no loss of bladder or bowel control, and his neurologic exam is normal. The question asks for the most appropriate next step. Run your red flag scan, find none, and think about proportionate care. Read the 4 options and choose your answer, then we will reason through them together on the next slide. Let us break this down step by step. First, spot the pattern. The stem deliberately lists the red flags and tells you they are all absent. There is no fever, no weight loss, no neurologic deficit, and no bladder or bowel involvement, and the exam is normal after a clear mechanical strain from lifting. That is textbook uncomplicated low back pain, and imaging is not indicated in the first several weeks. Second, apply the rule. For a patient with no red flags, the correct next step is reassurance, activity as tolerated, and simple pain control with a non-steroidal anti-inflammatory drug. That is the evidence-based first line, and it keeps care in the outpatient setting, so the answer is choice B. Third, eliminate the wrong answers. Magnetic resonance imaging is the classic overkill trap when there are no red flags. Plain radiographs are also unnecessary and add radiation with no change in management. A spine surgeon referral is far too aggressive for a first episode. The correct answer is choice B. Here is our second practice question, and this one is the cannot miss emergency of low back pain. A 52-year-old man comes to the emergency department with severe low back pain radiating down both legs after lifting. Over the past day, he has developed numbness around the groin and inner thighs, weakness in both legs, and this morning he was unable to urinate. On exam, he has decreased rectal tone and reduced sensation over the buttocks. The question asks for the most appropriate next step. This is a red flag stem on purpose, so read those neurologic findings carefully before you choose. Pick your answer, and we will reason through it on the next slide. Let us work through this answer because this is the one low back pain scenario you cannot afford to miss. First, catch the emergency pattern. The stem stacks the danger signs of Cauda Equina Syndrome: saddle numbness around the groin and inner thighs, weakness in both legs, an inability to urinate, and decreased rectal tone on exam. When you see that cluster, you are looking at compression of the nerve roots, and this is a surgical emergency. Second, understand why urgent imaging wins. The correct next step is urgent magnetic resonance imaging of the spine to confirm the compression, followed by emergency surgical decompression. Prescribing analgesia with outpatient follow-up and sending the patient for a 6-week physical therapy trial both dangerously delay care and risk permanent paralysis and incontinence. Plain films will not show the soft tissue compression. The correct answer is choice C, urgent magnetic resonance imaging. Let us go deeper on Cauda Equina Syndrome because it is the cannot-miss emergency of this entire topic. First, memorize the trigger cluster so you react to it instantly. The key findings are saddle anesthesia, new bladder or bowel dysfunction, especially urinary retention, bilateral leg weakness or sciatica, and decreased rectal tone. The moment a back pain stem mentions loss of bladder control or numbness in the groin, your hand should move toward emergency imaging and surgery, not conservative care. Second, image now and do not delay. The correct next step is immediate magnetic resonance imaging of the spine, followed by urgent surgical decompression, ideally within about 48 hours of symptom onset to preserve function. Any answer that waits, such as physical therapy, a repeat visit, or routine follow-up, is wrong. This is the one scenario where the aggressive answer becomes the correct answer, because every hour of delay risks permanent nerve damage. Here is our third practice question, and it tests chronic pain management. A 58-year-old woman has had low back pain for 6 months. Notice that the stem again tells you the red flags are absent. She has no fever, no weight loss, no neurologic deficit, and no bladder or bowel symptoms. A previous magnetic resonance scan showed only mild degenerative changes, and she has already tried non-steroidal anti-inflammatory drugs, but remains limited in her daily activity. The question asks for the most appropriate next step. Think about what actually helps chronic low back pain over the long term, and be careful of choices that either escalate too fast or add unnecessary risk. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, lead with active therapy. For chronic low back pain with no red flags, the evidence-based first step is an active program of exercise and physical therapy, often paired with approaches like cognitive behavioral therapy and non-opioid medication. Movement and gradual strengthening are the foundation of chronic back pain care, so beginning exercise and physical therapy is the correct answer. Choice A. Now the key distinction between the wrong choices. Starting a long-acting opioid is the trap, because opioids are not first line for chronic back pain and carry serious risk of harm and dependence. Repeating the magnetic resonance scan adds nothing when it already showed only mild changes and there are no new red flags. Referring for immediate spinal fusion is far too aggressive without a clear surgical indication. Every distractor either does too much or adds risk without benefit. The correct answer is choice A. Here is the single most useful exam day pearl for this entire topic, and it is the red flag fork. Every low back pain question forces you down one of two paths. When the STEM describes back pain with no red flags, take the conservative fork every time. The right answer favors reassurance, staying active, and non-steroidal anti-inflammatory drugs, and it avoids early imaging, so any choice that orders a scan or a specialist in the first few weeks is almost always the distractor. When even one red flag appears, take the escalation fork and let the specific red flag pick the specific test. Saddle numbness, urinary retention, or new leg weakness means Cauda Equina, so choose urgent magnetic resonance imaging and surgery. A cancer history or weight loss also points to magnetic resonance imaging, while trauma or fracture risk points to plain radiographs. Master this one fork, and you will solve the large majority of low back pain questions quickly and correctly. That wraps up our low back pain review for Step 3. Remember the core ideas we covered today. Scan every STEM for red flags first, and let their presence or absence decide between conservative care and urgent workup. For the ordinary case, default to reassurance, activity, and non-steroidal anti-inflammatory drugs, and treat early imaging as the overkill trap. Never miss Cauda Equina Syndrome, where saddle numbness, urinary retention, and leg weakness demand urgent magnetic resonance, imaging, and surgery. And for chronic low back pain, lead with exercise and physical therapy rather than opioids or surgery. The best way to lock all of this in is to drill low back pain questions in your question bank, read every explanation, and reinforce the concepts with a trusted board review resource. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.